Now we get to the electrocardiogram. Let's hit it off with the SA node first, because we just discussed pacemaker potential. So the cells in the sinoatrial node depolarize the fastest. They set the intrinsic heart rate because if one cell depolarizes first, the gap junctions it shares with its neighbors will automatically follow suit. So the impulse spreads through the atrial myocytes, and when they depolarize in synchrony, we get our P wave. So as the atria depolarize, the potential falls until the whole atrial muscle is depolarized and the potential difference ceases to exist. This is why the wave goes up and it comes back down. After the depolarization has spread throughout the atria, it will then hit the atrioventricular node. You can see that's here. The annular rings of fibrous tissue surrounding the atrioventricular valves, like this, are going to block the depolarization to make sure that it only goes to the AV node to the bundle of His. Do you remember a condition in which there's an extra pathway on the sides or somewhere that allows for conduction to not go through the AV node to the His Purkinje system? Well, we're talking about WPW, or Wolff-Parkinson-White. All right, now let's get back to the AV node. The AV node conducts the slowest velocity because its phase 0 upstroke is mediated mainly by calcium channels. Remember, it's a pacemaker action potential, right? So it depolarizes at 40 beats per minute compared to the SA node, which depolarized at 60 beats per minute. So that if the SA node infarcts, the AV node will have to take over as the pacemaker. Where does the impulse go after it finally makes it through the AV node? Well, now it's going to go to the bundle of His. It's sometimes called the common bundle because it gives off like a trunk of the tree that eventually gives off the right bundle and the left bundle branches. These are like literally branches of a tree coming off that trunk. These further give off even more specialized conduction tissue called the Purkinje system. The time that it takes for the atrial depolarization to make it all the way to the Purkinje system should be around 200 milliseconds. This is the PR interval. The Purkinje system has the highest concentration of fast sodium channels in the entire heart. For this reason, it is the fastest conduction tissue. Even though these cells are the fastest at conducting, they still have the ability to intrinsically, automatically depolarize at a very slow rate of 20 beats per minute. So all of the cells of the conduction system, the SA node, the AV node, the bundle of His, the Purkinje fibers, all of them have the ability to spontaneously depolarize. So I'm kind of giving you some confusing information, right? How can the Purkinje fibers act as pacemaker cells, but also be the fastest conductors in the heart? The only situation in which the Purkinje fibers would be allowed to take over is if you infarcted the SA node, you infarcted the AV node, you infarcted the bundle of His. This is how the heart has backup systems to prevent us from dying just from infarcting one part of our heart. Okay, so the depolarization made it all the way to the Purkinje system. Now the Purkinje system will depolarize the ventricular myocytes, and this creates our QRS complex. The QRS complex is included in the QT interval. The QT interval is simply the time interval between the start of ventricular depolarization until the end of ventricular repolarization. Now the QT interval is super important because abnormalities in ventricular repolarization can predispose a patient for early or late after depolarizations. This can actually lead to torsade de pointe, or even worse, ventricular fibrillation. We'll talk about these later. The T wave here is ventricular repolarization, right? It's the end of the QT interval. Watch out for inverted T waves. They may be a sign of myocardial ischemia. Be on the lookout for these. Now the ST segment is simple. It's just an isoelectric point between the S and the T waves. It tells us that the ventricles are depolarized. What about this J point here? It's the junction for J between the end of the QRS and the start of the ST segment. How hypokalemia or bradycardia create U waves is still being figured out. But if you see one of these guys, or if a U wave is mentioned in the vignette, think about low potassium or severe bradycardia as the reason. Alright guys, that was a ton of information, but knowing an ECG is one of the few things that is expected from all doctors, so you guarantee you're going to have to know this stuff. Now we reach torsade de pointes. It literally means twisting of the points. And with this, you may see different waveforms with a heart rate over 100 beats per minute, hence the term polymorphic ventricular tachycardia. So as you look at the tracing, it appears that all of these QRS complexes are literally rotating around an isoelectric baseline. Well, we'd expect the baseline to be here, but it's just not there, right? This is because all of these are abnormal QRS complexes. So let's quickly review repolarization so we can understand how the inhibition of potassium channels can prolong the QT interval. Then we'll talk about how QT interval prolongation can predispose us for torsades. Now remember, back to phase 3, it is predominantly due to potassium efflux. This is called the IKR current. Now let's look a little bit further and talk about this potassium channel itself. It's a transmembrane channel. The flow of potassium across this channel is important for phase 3 polarization. Now, lots of drugs listed in your first aid book can actually come and just sit in this channel, compete with potassium, so that now we have to compete and therefore we prolong the ability of potassium to flow across and complete phase 3 polarization. Blocking potassium channels in one area of the conduction system next to another area of the conduction system that does not experience the block disrupts normal conductivity. So essentially what happens is that we have cells that are still repolarizing right here next to other cells that are just fine, and they're going to depolarize again. So now we create a little circuit where these cells come over, and then as soon as these cells finish repolarizing, they are now depolarized. And we have created a little microcircuit loop of repolarization and depolarization. We have two tissues at different stages in the action potential. They are unsynchronized because one has a long QT interval and the other one has a normal QT interval. This is super dangerous, right? We've created a new depolarization loop from tissues that are adjacent to each other. This tiny waveform loop of reentry is going to continue to loop over and loop over and loop over on itself at a rate of at least 100 times. This creates 100 beats per minute, leading to the polymorphic ventricular tachycardia or even potentially ventricular fibrillation. This leaves us with ventricles that are fibrillating or quivering instead of contracting together. This is because there are so many loops of depolarization that the cardiomyocytes in the ventricle that are never told to contract at one time together. They're fibrillating and quivering at different times. There's different or polymorphic waves of depolarization. So this is the polymorphic ventricular tachycardia known as torsade de points. High-yield things to remember are classic drugs that will prolong your QT. People die from these. You have to know them. What are these? Well, quinidine, big-time classic drug. No one uses this anymore unless you want to kill someone. Macrolide antibiotics. People use those. Be on the lookout for this. Psych drugs such as haloperidol, extremely heavily used. And also tricyclic antidepressants. These will show up on your exam. One drug that's used all day, every day is ondansetron. This is an antiemetic used by every single type of doctor. Also, be on the lookout for very low magnesium levels. This can cause hypokalemia. So remember, we said be on the lookout for low magnesium levels. The reason this happens is that magnesium is crucial in limiting the amount of potassium that leaves from the principal cells of the convoluted tubule via this channel. So low magnesium means lots of potassium flows out of these principal cells in the convoluted tubule into the urine. Low potassium predisposes you for QT prolongation, predisposing you for torsade de points. Now, how do you treat it? Well, replace what's being lost. Give them magnesium, right? So, can you remember another condition that we treat with magnesium sulfate? How about eclampsia? All right, you have to know that. People don't like pregnant women to be sick. Now let's push on to examine one of the things we've mentioned that predispose us for torsades, congenital long QT syndrome. So we discussed the IKR current that's responsible for the timely repolarization of cardiomyocytes, but this can be blocked by certain drugs, right? So now we're going to talk about how people can be born with specific mutations of the potassium channels that can actually place them at risk for QT interval prolongation for their whole lives. Now let's look at this table real quick. We're talking about Romano Ward and Jervel Lange Nielsen. These are congenital long QT syndromes associated with mutations in the genes responsible for coding the structural components of the potassium channel itself, or the proteins that are going to insert them into the membranes of the cells that they need to be put in. So what's the difference between the two besides crazy names? So Romano-Ward is autosomal dominant, while Jervell-Lange-Nielsen is autosomal recessive. Why is it that only Jervell-Lange-Nielsen has sensory neural deafness? Well, we'll just explain it right here with this image. Turns out that these patients also have abnormalities of potassium channels of the cochlear hair cells. This is represented here in this diagram. Remember, the cochlear hair cells are in the inner ear, so this diagram shows us the teardrop-shaped hair cell responsible for taking the vibrations of sound and transforming them into a neuronal signal that the brain can interpret. So if the potassium channels here on the hair cell are not functioning, it's going to be really hard, actually impossible, for the hair cell to send afferent signals to the brain. These cells cannot repolarize, therefore they cannot continue to send multiple signals to the brain saying, hey, we're hearing something. So for this reason, JLN, Jervell-Lange-Nielsen syndrome patients have sensory neural deafness. So back to our table, notice that Romano-Ward is cardiac only, while JLN has this sensory neural deafness component. Extremely high yield, because that's the only way you differentiate the two is autosomal dominant, autosomal recessive, and then the one that has deafness. Alright, now we go to Brugada syndrome. So Romano-Ward, Jervell-Lange-Nielsen were abnormalities in the potassium channels. Brugada syndrome is abnormalities in sodium channels. And this is an autosomal dominant inheritance pattern due to a mutation in the cardiac sodium channel, most commonly seen in Asian males. The mutation results in a decrease in the ability of cells to have sodium come inside of them. This is particularly affecting the epicardial and the endocardial cells, but not the myocardium. So this means that we have different depolarization frequencies in tissues of the heart that are right next to each other. So again, we set ourselves up for creating microcircuits. So these are going very slow because there's a decreased ability of sodium to enter these cells, while these are going pretty fast because they're pretty normal. So now these can go depolarize these, and then they can loop back and loop back and loop back on each other, creating microcircuit depolarization. So this unbalanced depolarization activity also leads to unbalanced repolarizations throughout the ventricles. This is going to show up on the ECG as ST segment elevations. Now on ECG, you would see ST elevation and something also called pseudo right bundle branch block. So how do you treat these patients? Well, these patients are incredibly high risk for fatal arrhythmias. You're going to go ahead and put an ICD and prevent that from happening so you can set the intrinsic depolarization rate if anything goes wrong. What is an ICD? It is implantable cardioverter defibrillator. In these patients, because these arrhythmias can lead to VFib, we need to make sure that we stick these in here and prevent sudden cardiac death from VFib. You won't have to read an EKG on this complex syndrome, but be prepared to have EKG findings described to you in combination with a vignette that says an Asian patient with a positive family history of ventricular fibrillation or sudden cardiac deaths. The way the ICD works is that the ICD is put directly underneath the skin, and then the leads are put inside of the heart so that the tip of the lead is in the ventricle so they can depolarize the myocardium. You can see here it's sending electrical impulses.